I'm Christopher Newman. I'm the chair of the Scientific Committee of the European Academy of Childhood Disability, and I have the pleasure this afternoon of hosting this session on genetics, ethics, and childhood disabilities, and to look with my co-speakers into what the future could probably hold. Our organizing group, it seemed to be an important topic to actually tackle this afternoon because we're all probably more or less familiar with the big improvements and changes in the field of genetics that have happened over the last 2 decades. But they do have major ethical implications, and especially in the field of childhood disability. And this is one of the topics that we wanted to discuss today. So to do so, I have 3 co-speakers with me who will successively do short 10-minute presentations. And at the end of that, we're going to be having a conversation on this subject of genetics and ethics. And please do feel free to kick in via the Q&A, which you have at your disposal. I'll be checking them as a moderator and will be very happy to bring them into our discussion. So let's move on. I'd like to introduce our first speaker this afternoon, who is Professor Laurent Servais, who is, I'd say, recognized worldwide for his expertise in the field of neuromuscular disorders in children. He currently is a professor of neuromuscular diseases at the Oxford Neuromuscular Centre. He's also an invited professor of child neurology in Liège University. He's been very proficient in terms of research, especially in the field of genetic therapies in spinal muscular atrophy and Duchenne muscular dystrophy. And he will surely show us some pretty impressive results, but also a certain number of questions that they do raise about basically changes that have happened over the last 3 to 5 years. So Laurent, the floor is yours, and we're looking forward to listening to you. Thanks a lot.
Yourself, Laurent. Laurent, we can't hear you. It's technical support. Please unmute yourself. At the bottom of the net, over there. Perfect.
Sorry. Can you hear me?
Yes, thank you.
Yeah, I was just thanking Christopher for his kind invitation and presenting my disclosures. So I will actually briefly discuss with you the principle of gene therapy and giving 3 examples, and then discuss always efficacy and safety, because there is a huge buzz about gene therapy and the fantastic results that we have observed, but we should also consider the safety issues. The basic principle, it's to transfer a part of the DNA using a vector, which is today in most of cases an AAV vector, so that this vector will bring this piece of DNA into a cell and will lead to a secretion of a protein or a protein receptor or intracellular protein, or the modulation of another gene. And just to figure out the amount of virus that we deliver to a kid, well, the classical dose is 1/10^14 Vg per kg, which means this number of virus in a 3 months old, right? What does it mean? Actually, you cannot imagine what it means. So to give you an idea, let's imagine that 1 virus is a coin of €1, right? And let's make a tower 1 meter length, 1 meter width of this pieces of €1. It will cost me €1,849. And let's make a tower with all these virus. Each of them is a piece of €1. Okay, so each meter of my tower will cost me €794,562, right? So would my super tower with the dose I will give to my patient 3 kilo be as tall as the Eiffel Tower? Will this super tower that costs €794,562, could it constitute a bridge between Paris and New York? Could it turn around the Earth? Well, actually, the answer is not. My super tower that costs €794,562 per meter can go to the moon. This is not the right answer, because the right answer is that it can go to the moon and back. And this gives you an idea of the amount of virus that we inject in the patient. So, you know, maybe Paracelsus, he was a very famous colleague born in 527 before Brexit. And he said something very interesting, which is the dose makes the poison. And that's exactly what we observe in gene therapy. So first example, spinal muscular atrophy. Now we have a gene therapy product that is approved, anazemenib Pavlovec. And this is a devastating disease of children, right? Especially the type 1, in which patients will die before the age of 2 years in absence of treatment because of the degenerescence of the motor neurons of the anterior part of the spine. So the first paper was published in the New England Journal of Medicine in 2017. And look, this is in a disease in which patients will only regress. This is the fantastic improvement of these patients when you inject high dose. Okay, and well, let's forget about this data and let's look at a patient. This young patient has been injected with gene therapy, and of course, without gene therapy, he will be dead today, right? He will, yes, SMA type 1. Is not that at all. Is doing quite well. He has some upper limb function. He is not a walker, and I believe he will never be, unfortunately. But he's a painter, and he is doing better. Unfortunately, these patients will forever have a severe disability. But we have another trial ongoing with the same product and the same disease. And when we inject these patients before the symptoms rather than after the symptoms, the question is not how much they improve on a scale. The question is how much they are normal. And look at this. This is actually in gray, the corridor of normality in the Bayley score. The patients that we inject before the symptoms, not only they don't die, not only they progress, but actually for most of them, if they have 3 copies of a pseudogene that we call a SMN2, they are normal. If they have only 2 copies of the pseudogene, they are in 50% of them normal, and in 50% of them mildly delayed. This is the first patients in Europe that we injected before the symptoms with the gene therapy product for SMA. This boy was normal before the injection. The good news is that today is still normal. So the first lesson that we have to learn from that is that if we want to get the best from gene therapy, we have to use it in the best indication, and time is extremely important. So we don't need only the product. We need the intelligence to use it in the best setting. And there are serious adverse reactions. In the FDA documents, you will find that several patients presented not only high increase of liver enzyme, but also TMA, so thrombomicroangiopathy, and one of these patients unfortunately died. Some of the hepatotoxicity can be severe, especially in the older patients. So we need to select these patients properly. We need to apply it when we have the best benefit to risk ratio, and we need to do it very carefully because there are safety issues that may happen and that we need to learn how to manage. SMA is a disease of the motor neurons. DMD, Duchenne muscular dystrophy, is a disease of the muscle cell. And there are several common points for gene therapy, but there are major difference. And one of these difference is that actually motor neurons remains the same number for the whole life, and muscle cell is constantly in remodeling. There are several approaches for DMD, for Duchenne muscular dystrophy, and you have probably heard a lot about microdystrophin with a lot of excitement in the community, with a lot of patients coming from all over the world in our center just to have a chance to be part of the trial. But what we must be honest on is that in several of these trials, there are safety issues, which is complement activation, TMA, pseudohemolytic uremia syndrome, and we must be able as doctors to listen to the wish of our patients to come into the trial, but to mitigate expectations, to temperate expectations and say, well, okay, this is promising, but First, we still don't know about the amplitude of effect. We still don't know for how long the effect will last. And we still have safety concerns and safety issues. So even if for Duchenne, gene therapy brings a complete new, different kind of hopes, we must be extremely honest and temperate the expectations of the community by myopathy, in which patients have probably one of the most severe disability I've ever seen in my career of child neurologist. Nevertheless, when injected with a high dose of gene therapy product, these patients improve remarkably, and they can acquire motor function up to walking. And this is in terms of hours of ventilation, rather than to be on 24 hours a day of ventilation. Some of them could be also weaned off the ventilator, which is a major success. But unfortunately, in the trials, 3 patients died. And they died of hepatotoxicity because of the massive dose of virus that we injected in these patients who have a pre-existing hepatic condition. So we have on one side an effect of a magnitude which is such that it's transformative for the patients and the family, and on the other side, a potential extremely severe side effects, which means that we need to carefully select our patients, we need to mitigate the expectations, and we need to be very careful of the safety of these patients. So that's why I wanted to tell you today, gene therapy can be highly effective and life-changing treatment in genetic disorders, but there are safety concerns. We need to continue to robustly safety monitoring. And we still don't know about long-term data, which means that we need to be extremely honest and transparent with our patients when we propose these medications, and to keep it for well-selected case in well-selected centers. Thank you very much for your attention.
Thank you so much, Laurent, for an excellent talk. And as said previously, I mean, things have changed so fast over the last years, and seeing those results of gene therapy and also visualizing them with those videos is very impressive. And as you very well mentioned, I mean, there are those issues around side effects. Something that we might also come back to later is the question of cost. Again, a lot of ethical questions around this, but yeah, it was a great and very clear presentation. So now we're going to be moving on to Dr. Jonathan Roberts, who's a researcher in the Society and Ethics Research Group at the Wellcome campus in Cambridge. He's actually a genetic counselor, and he also has a clinical activity in Addenbrooke's Hospital in Cambridge. And his research focuses on basically how developments in the field of genetics impact society, with a specific interest in basically how genetics are portrayed in popular culture and questions around identity. So in addition to actually his genetic counseling practice and his research, he has a very rich professional experience, including working as a special needs teacher in special needs school, both in the UK and Poland. So, Jonathan, we're very much looking forward to listening to you talking about, well, you can see it on screen, disability and genetic screening. Thanks, Joe.
Thanks. Can you hear me?
Yeah, we can hear you.
Great.
And we can see you. Yeah.
And can you see my
your slide yet?
Okay, let me just share the screen. Let me go. Okay. Right, can you see my slides too?
We can see your slides, but not in full screen mode. I don't know if somebody from the technical support can kick in. Yeah, thanks.
Technical support. Could you go, when you share your screen, can you click on entire screen, please? And then go to full screen mode as well.
Yes.
So share screen, choose entire screen. And now here, if there is like a presentation mode, if you could click on that, so it would be a full screen, because now we can see your toolbar and the slides on the left.
Yeah, okay.
Yes, that should work over there.
Is that working now?
No, not
No.
yet.
Okay, it looks like it's full screen on mine.
But we can see it okay. I guess we can go on like that. It's workable for us if you want to move ahead.
Yes. Okay. Okay. I'll try one more time. So share screen, entire screen. Let's try this.
Here. Would you be so kind to try to share your screen again? Sorry. Thank you.
Okay.
Thanks. Now we can see it.
Okay. So sorry for that. So my name is John Roberts. I'm a genetic counsellor. I work in both clinical practice and research. And I'm just going to give a kind of an overview of things, in terms of some of the ethical issues that we have in terms of disability and genetic screening. I think it's difficult to kind of talk about this without necessarily seeing that kind of history of eugenics, which is something that kind of has hung over sort of genetics and issues of disability for a decent amount of time. Eugenics was sort of the 19th and 20th century concerns with reproductive health and inheritance, and was kind of mixed in with all sorts of scientific, political, and other kind of concerns. And often eugenics may kind of get dismissed as kind of bad science. One of the challenges is that it was at its time, it was a respectable form of scientific pursuit, which I think we need to remember, because we may think of things that are respectable now, but are still ethically challenging. So just because something is accepted and something is a respectable form of scientific pursuit doesn't mean that we can't be critical and examine of what some of the ethical assumptions that were made in that. And key to eugenics were the sort of overtly problematic ideas about what defines a worthwhile life, who has worth to society, and these are ideas that we will come back to kind of a little bit later, just as we kind of go through some of the issues of disability. I guess one of the issues is that these, as indicated by eugenics, these are not new issues, but they are old issues given new impetus by technological innovation. So you've got things like whole genome sequencing, non-invasive testing, pre-implantation diagnosis, and also gene editing. And each of these technologies can give these kind of old issues that have been around for time kind of new impetus. And in terms of the whole genome sequencing, one of the key issues is the time frame, so the speed at which you can get results. But it also massively increases kind of what's possible. So, for example, one of my first genetic counselling jobs was working on the DDD project, the Deciphering Developmental Disorders project, and the time frame for kind of results was a couple of years. The first human genome sequence took 13 years, and now within 4 weeks in the NHS, a whole exome sequence, trio exome sequence, can be turned around for families when a genetic diagnosis is sought. So the time frames are really incredible in terms of that speed. The non-invasive testing, so this is where there's fetal DNA which is circulating in maternal blood. Increasingly, this is able to be used for genetic testing. At the minute it's reasonably limited in what we can offer it for, but it's increasing all the time, and is not inconceivable that whole genome sequencing will be combined with non-invasive testing to offer sort of new and advanced screening in pregnancy. One of the important issues about non-invasive testing is that there's no miscarriage risk, and it can be done a lot earlier than invasive methods like CVS or amniocentesis. We also see pre-implantation genetic diagnosis, which is where it's a form of IVF, but where there's a known genetic condition in the family. In the UK at least, the PGD is available, and you select the embryos so that those that don't have the genetic diagnosis aren't used. And then, of course, there's gene editing and CRISPR-Cas9 and all the kind of potential breakthroughs and benefits that may kind of arise from that. So there's a range of new technologies that are kind of coming in and are either new or being able to be used increasingly easily, accessed increasingly easily, that are giving a new impetus to some of these old issues. So I guess that kind of begs the question, well, kind of what are these issues? Well, I guess for whole genome sequencing, one of the questions is a bit of a practical question. It's a health service, increasingly around the world that are put under stress, and often it's not sort of clear when a lot of these conditions are rare, what the benefit of whole genome sequencing for kind of carrier screening would be. So there are kind of practical questions, and I think those questions take on an ethical consideration, especially in terms of kind of resource use in pushed healthcare systems. It's important, I think, also to think about definitions of disability, and coming back to this idea about what judgments have been made about what is a worthwhile life. And this comes back to importances in terms of the social model versus the medical model of disability. So just this is the thing where it's really important to consider the genetic underpinnings of disability, but at the same time many people would argue, and there's two examples here in terms of one from a recent story in the BBC about people with Down syndrome questioning kind of late termination, and also from Tom Shakespeare, who's just kind of demonstrating that the society in which you live gives shape and meaning to disability and how severely that is experienced by people. That's a key issue, I think, kind of going forwards in terms of thinking about genetic screening. And also, I think there's an important question in terms of equity in terms of genetic screening. So there's an element to which who has access to this screening? Is there a certain group of people who, if this is preferentially offered, you can kind of opt out of genetic risk? And I think importantly, what that does is it means that it gives the possibility for there to be stigma attached to certain choices. In terms of people, who choose either not to opt out of that genetic risk, or people who aren't able to for whatever reason, even if you see it in that way. So, there's issues that I think have been kind of long-standing in the idea of genetic screening, but have been given a kind of a new importance with many of these technologies, especially thinking about kind of whole genome sequencing and non-invasive testing and pre-implantation genetic diagnosis. So sort of in summary, so much more testing is possible, in the the healthcare space, and also in the direct-to-consumer space, which is another important issue in terms of what's available in a healthcare system, and also what's available privately. And important issues remain for carrier testing and related disability. One is the practical value of that. One is to consider, the models of disability, the social models of disability, and the judgments that are being made about what counts as worthwhile life. And there are important issues of equity going forward in a range of contexts in terms of who has access to this new technology. So thank you very much.
Thanks a lot, John. That was a very interesting presentation. Picked up a lot of strong ethical issues that I'm sure that our next speaker is going to react to, and then we'll be able to debate them. So our next speaker is Professor Kristien Hens, who's a professor of bioethics at the University of Antwerp and a guest professor at KU Leuven. We could not have her because she's basically the PI of a big ERC-funded project, which is called Neuroepigenetics. So of course, with the theme of the day, she fit perfectly. Our research interests are specifically in ethics of genetics and reproduction and on the normative implications of concepts of biology, and specifically, and that's why this interests us at the EACD in the context of neurodevelopmental conditions, with a special interest and focus on autism. So Kristien, we very much look forward to listening to you and to the discussion that will follow. Thanks.
Yes, can you hear me? Okay, thank you.
We can hear you. And see your slides.
Thank you, fantastic. Okay, thanks everyone for having me here. It's my pleasure to talk to you about some of the ethical issues that were already introduced by the previous speaker. It's nearly impossible to fit an ethical discussion of genes and childhood disability in 10 minutes. But I'll try to give an overview of certain ethical issues, but I will warn you in advance, I'm not the type of ethicist that will come with answers right away. I think ethics is about thinking about questions from all kinds of different aspects and then coming to maybe a conclusion, but it's far too early to come to a conclusion after 10 minutes. Okay, so we've been talking, I was already introduced, as said, I'm a PI of a project specifically focusing on concepts of biology with regards to, Tourette, AD, ADHD, but for the last 10 years I have been thinking a lot about autism, and I'll maybe also use that a bit in the upcoming slides. I'm also involved with a project called Tiara, tracking infants with an increased likelihood of autism, and maybe I will draw on that also a little bit in the next slides. Okay, if we think about bioethics and about genes and about disability, bioethicists, they think about these kind of therapies, kind of new technologies that we've seen in that previous speakers have introduced, like carrier screening, like gene therapy, like the non-invasive prenatal testing and pre-implantation genetic screening and the likes. And as an ethicist, ethical questions on these technologies, they usually take the form of what is the risks? What are the risks? What are the benefits? How do you weigh them? Is this different when you consider children than when you consider adults? What kind of information should we know from our genes? What kind of information should we return to patients or to their parents? What kind of rights have parents to know certain genetic information about their children? What about consent? How can we get consent for people who cannot consent or who because of their disability, for example? What is the level of what can parents decide for their children? Can parents decide for their children to enroll them in very experimental therapies? Who has a final say there? And how do you weigh that against the right of practitioners to have their say as well, to have their opinion as well on certain issues? But I think when we're doing ethics, these are the specific questions, specific technologies we often think about. I think when doing ethics, it's also very important to ask ourselves, what are we actually discussing? And in the next 3 slides, before coming back to the ethics, I want to focus on some conceptual issues, which are more philosophical issues, but I think which are relevant in how we actually think about ethics. And the first thing is about genes, about the meaning of genes. When I started out my PhD 15 years ago, this was about the use of genetic information, the DNA from children for research. And at that point, genes were all over the place. They were very important. Genes would tell us everything, etc., etc. And I guess still now people have the impression that as long as we understand genes, we will be able to predict certain things about the lives of, for example, future children, if we're talking about reproductive ethics. There is this, in the media, there is also this use of information metaphors of genes that are like book of life, the way in which we can understand things, the way in which we can read things. And maybe if we're talking about gene therapy, or if we're talking even about gene therapy in embryos, like this movie that we always have to give as an example as ethicists, maybe even control genes in embryos to decide which kind of people there are. But I guess if the more we think about genes and the more we know about genes, the less clear-cut this vision becomes. I myself am involved in autism, and I started out researching the ethics of autism genes. And yeah, of course, we all agree that autism is a condition with a genetic basis. There's a lot we don't know about its development, and on the one hand, this genetic component of disability, of neurodiversity like autism, is very important. I have talked to many parents of autistic children, but also to many autistic adults themselves, and the idea that they had a condition that was in their genes that sort of helped them to cope with it. It's how I am. It's not. It cannot be changed. People have to accept it. On the other hand, the idea that your condition is in your genes can also lead to stigma, specifically regarding, yes, you are like that, you cannot take responsibility, there is no hope, there is no cure, except these technological things. But I guess maybe this view on genes is somehow obsolete. We know that genes are not. Genetic research has not delivered on its promise to some degree. In other aspects it has, but in some aspects it hasn't. But still, how we think of genes is also influencing how we think about ethical questions regarding information, regarding changes, etc. I think it's also important to ask ourselves, in how far can genetic information tell us something about what is a good life, about what is well-being? Can we really read how someone will lead their life based on genetic information? And that's the next concept that I think is important for ethics, and that is, what do we mean when we talk about disease, or what do we mean when we talk about health? I think there are two ways of looking in philosophy of medicine. There are two ways of looking at health and disease. One way is stating that is the naturalistic way. It's stating that a pathology is something objective. It's like it's a deviance from a statistic normality, or it is something that you can read in your biology, a lesion or a gene or an infection, etc., etc. Regardless of whether you're aware of that, regardless of whether you suffer from it. But on the other hand, philosophers like George Canguilhem question it. They say there is no such thing as a pathology that's merely located in the individual. A pathology, a disease, is always about a mismatch between an organism and their environment. And an organism that where there is a mismatch in the environment, that the environment does not suit the organism, suffers, and that is what a pathology is. And this, of course, sheds a whole different light on the question of how should we deal with disability? Think about autism. Is autism something that is located in the individual? There is something with their genes, with their brains that we should fix, or is autism more something that we should accommodate, that we should welcome a variety, etc.? And then we come to the next conceptual issue that I want to discuss, and that is, of course, related to concepts of disease, and that is concepts of disability. The previous speaker, John, has already talked about the models of disability, and I want to repeat them here because I think this is important. If we are talking about disability, are we talking about something that is located in the medical sphere, something that needs to be fixed, that needs to be prevented, that needs to be cured? Or, and that's a social model of disability, is disability and well-being, are they not one-to-one related? Can we not say that disability has more to do with the support that a society offers for a specific type of person? And of course, whether you look at it, it influences how you think about the ethics. If you think disability is something within the individual that needs to be fixed, you will focus on cure. If you think about disability as something that happens in the interaction with the environment, then maybe we should think more about accommodations, etc., etc. Now, more recent models of disability go beyond this ambiguity, and I think that is really interesting. If you think about, for example, what I'm used to think about, autism and neurodiversity, and you talk about autism, you talk with autistic people, they would, for example, say, well, it's neither purely something medical nor purely something social. It's about living with a specific body in a specific environment. And sometimes things bother me. And I think these things that bother me, these are the things that we should try to maybe fix, maybe even with medicine. But on the other hand, my being autistic in itself I don't see that as a disease. The more recent theories are often, there is CRIP theory, which is a model, an approach to disability, which focuses on this personal experiences of embodiment, of living with a specific body, which can be neutral in one respect, but which can also be challenging in other aspects. And this, I would recommend everyone this documentary on Netflix. Okay, I'll have to quickly go over this. This is, for example, a quote by Harriet McBride Johnson. She had a degenerative muscular disease, and she was a disability activist that went into discussion with Peter Singer. Peter Singer is an ethicist who had these claims like it's better that disabled persons, that they are not born. He would advocate for prenatal diagnosis, prenatal screening, etc., etc. And then Harriet McBride Johnson, she discussed this with him, and she said, "How can you say that to me? I'm fine with who I am. Why should people like me be prevented? Why should we expect that people who don't fit the idea of normality be prevented?" Okay, now back to the ethical questions. I think these conceptual issues about what do we mean with well-being, and is well-being really something that we can read off our genes, even in embryo. This embryo will be less happy than the other embryo. Can we really do that? And these kind of ways of these conceptual issues, they reflect on the answers we may give to ethical questions. And I think there are still a lot of ethical questions about childhood disability that we as an ethicist need to do more more research on. First of all, this is the status of the child. I think we have been assuming a lot of things, lots of things about children, about the relation with the parents, about the rights of children, that we actually should reconsider. For example, I was part of a research protocol that did a lot of biological but also psychosocial tests with children, and there we thought about what kind of information should we return to the parents. And originally people had the idea like, okay, parents have the right to know each and everything about their children, genes, IQ test results, etc., etc. But if you look at it from a children's rights perspective, it becomes more problematic. Well, why would that be the case? Maybe the relation between the parent and the child will be disturbed, etc., etc. What should be the aim of genetic research? Gene therapy, prevention, reproductive choice. While I interviewed once professionals dealing with autism genetics, and they said, well, it's very important. It's very important that we do genetic diagnosis of families when there is a child with autism, because then the parents, they can decide whether they want the next child or whether they want to access certain reproductive technologies to avoid a second child being born. And on the one hand, this is very understandable. Raising a child with disability can be a lot of work. But on the other hand, of course, we can reflect on what kind of message are we giving to the existing child, well, about their disability, about their being in the family. Who gets to decide what kind of research should be done? What is important in research on disability? In autism, so this has been framed before as, okay, autism should be cured, but then autistic people say, no, you should investigate what I think is important that I need help with. So we want stakeholder engagement. We want to hear, as ethicists, we want to hear from those that are actually affected, even if they are children or if they cannot speak or are intellectually disabled. But I'm going to go a little bit quicker. In order to do that, we meet of course some problems. If you want to do stakeholder engagement, if you want to investigate in learning more about the phenomenon of being disabled, you automatically meet the problem that those who want to speak about their disability are maybe not representative for other parts. So how do you engage people who are typically not represented in stakeholder engagement? And I think this is another question that we should deal with in the next couple of years as ethicists. And to end, I want to say, if you want to solve ethical questions, I don't think there is such a thing as a perfect ethical answer. You have all these different stakeholders, parents who have a view on disability, children, future children who do not exist yet, you as a clinician who has your own values. And I think what bioethics want to do is not to apply these big principles of autonomy, of maleficence, of non-beneficence that you have all had to study before, but to really think about specific situations, specific approaches, specific experiences. And to end, I want to show you, so I think that ethics research should reflect more on specific cases rather than thinking in general terms about this disability. I think what we bioethicists should research more also is how we can be more sensitive to values, to cultural context. For example, in certain cultural contexts, the meanings of genes will be totally different than in another context. In certain cultural contexts, the rights of parents towards information about their children will be different, etc., etc. And I think research into experiences of disability should be part and parcel of any ethical reflection, also with those who do not speak or are difficult to reach. And I think, I just want to make some publicity here. It's also part of what we're trying to do in my research project. I have a postdoc, Leni van Goitsenhoven, who's using art-based methods to try to find, to investigate the experiences of disabled people who do not speak. And she has done a big an arts-based research project with, in this case, it was Helene. Helene is an 18-year-old woman who doesn't speak, who has several disabilities. And it's very beautiful. She has now an exhibition about it. But now I'm going to stop because I can go on talking about this. And I would like to give the floor back.
Many thanks, Kristien. If we can go into panel mode, please, for the technicians. Yeah, great. Well, thanks to the three of you. I know I've imposed you a very difficult exercise to actually go into these complex subjects in so little time, but I must say you've all done a tour de force from that point of view. It was really, those were three fantastic presentations. Sadly, that doesn't leave us much time for discussion, especially after I'll be moderating the next session, but and as Kristien very well said, ethics probably raise more questions than the answer, but having heard you and having heard how far the technology is changing things, be it for, gene repair or, condition repair, prevention, reproductive choices, do you think that the actual ethical discussion is given enough space within society, or aren't we being too biased towards these fantastic technological changes? What's your feeling from that point of view? Is the ethical debate happening as it should be happening, or not? Yeah, Kristien, go ahead.
Yeah, I think it's I can talk about my experience of years as a bioethicist, and I think the ethical discussion both in the society as well as in research protocols is much improved. I think 10 years ago, 15 years ago, the ethicists, we were allowed to join research protocols to think about how do we write a consent and how do we think about privacy. But I think ethicists can do much more about that. They can ask relevant questions. They can talk about concepts that are maybe very straightforward for researchers, but that may not be so straightforward for ethicists or for the people having the condition. So I think there is a lot going on, and it's the societal discussion is really taking place now. But what I do regret is that sometimes it's very polarized. I'm from autism. I'm in the autism. I'm interested in autism, and I see often a lot of polarization there of autistic people, and I understand them. They have been ignored for a long time, but at some points we need to find a way to talk to each other and to integrate different perspectives. But I'm hopeful.
Jonathan, would you like to comment on that?
I think one of the big challenges going forward, I think, I think it's kind of been, as Kristien mentioned, is bringing in, varied and disparate voices into the conversation, and then I think the more people who you allow into the conversation and the more voices are listened to, I think the more likely you are to have the type of discussion that needs to be had. I think what we can do is move away from trying to necessarily pinpoint exactly what is and isn't the ethical thing to be doing, but what is the type of discussion that you should be having in order to make ethical. What's the process? And I think the wider you've cast your net, and the broader you have that discussion, the more likely you are to be having the type of discussions that you can call that process an ethical one. And I do think that's one of the big challenges going forward, because I think I think, as someone has said in the comments, both the medical and the social model of disabilities, are kind of one important aspect of the explanation. In order to understand what that means for an individual and means for groups of people, it is a complex thing. So I think, broadly speaking, and I think there's a good move towards that. I think I'm kind of seeing in the way that studies are developed, in the way that we're kind of making decisions. I think that's accepted, and I think people are kind of finding ways of having those discussions that allow for different voices to be heard and brought into the decision-making process.
Thanks a lot, Laurent. You're a clinician and you actually provide some of these therapies. What's your point of view on this? Is the debate happening as it should be happening?
Probably not. So I think that first, when it comes to children, because I'm a pediatrician, you bring another layer of complexity, because what parents feel to be the best for the child can be the best for the child, but sometimes it's not. We can debate for hours, probably even longer, about it was always the right of parents to decide if a child can be treated or not, should be treated or not, what is the level of risk that is acceptable, what is the level of benefit risk that is acceptable. And then and we had several discussions, questions on the chat about that, when it comes to the cost of this intervention, not only this intervention, but also all the care around. It also involves another layer of complexity, because of course we are a universe with limited resources, so the resources that we place somewhere are not used somewhere else. That's a matter of fact, right? So what is the level of responsibility and of right of parents when it comes to a pediatric patients? It definitely add a level of complexity, and this is something I'm really facing with parents of, for instance, pre-symptomatic patients who are sometimes hesitant to deliver a drug that can make their child normal, and if not, the child will be disabled. And we know that or parents who are willing to get 2, 3, 4 drugs together, regardless of side effects, just because they want us to push the envelope, and regardless of the risk and of the cost. So, it brings certainly another layer of complexity.
Thanks a lot, Laurent. I'm so sorry I actually have to interrupt this discussion and finish here. What we will have to do is probably see each other, invite you back to a real EACD physically in one of our next meetings that we'll be talking about later. Well, again, thanks a lot to the three of you. As I said, it was a real tour de force presenting what you did present, and you did it, very efficiently and very clearly. So, wishing you all the best. Thanks a lot, and I'll be seeing everyone else in 4 minutes in the next session with Beza Unal and Judy Human for the LSAS talk.